of ourselves in space, proprioception, where are we in
Bien,
space?
acá lo que tenemos
We do that by the
es
combination of
un
modalities.
examen
We do that
semiológico
combining our
con
sense of where
respecto
our
a la
arms
parte
and
de
limbs are in
sensibilidad, ¿no?
space, by
El
using
profesor
our
está
eyes to help
explicando
fixate that,
respecto
by
a
using our gyroscope, if
que
you will,
tiene
the
que ver
vestibular
por
system to
parte
help us
del
with balance.
paciente
When all three of those are working
colaboración,
together,
¿no?
we are very,
Colaboración.
very secure in knowing exactly where we
Entonces,
are in space.
lo que vamos a
When
hacer
one of
es,
them
vamos
out,
a
we
ver
can usually
todo lo que es
compensate very well with the other two.
la
But as
sensibilidad,
anyone
¿no?
knows, if you're dizzy
La
in a dark
vibratoria,
place, you're
¿no?
very
La
uncertain of where you
proprioceptiva.
are in space. So losing one or modality, we can usually compensate. If you lose vision, vestibular function, or proprioception in any combination of more than one, then it's a severe impairment. You have to keep that in mind when you're listening to the story of a patient or watching gait or watching their balance to understand that
Vamos a ver
it's
el
actually...
tacto.
We're now going to review the sensory examination. Sensory examination is very difficult because it involves many different parts of the body. You need to have a sense of the structure of the nervous system and actually a sense of what you're looking for. The other thing that's very important is you need a cooperative patient. The patient is really able to give you appropriate feedback when you test each of the modalities. It's really impossible to do a sensory examination on an unconscious patient or an uncooperative patient. Patients in severe pain, for instance, are very difficult because they're so distracted by the pain, it's difficult to do a good sensory exam. There are really three different levels of sensation that we have. We sense the exterior world, what's going on around us, and there are four modalities that we use to sense that world. We sense touch and pressure, we sense pain, we sense temperature, and we sense our position in space, proprioception. Where are we in space? What's the position of our limbs? There are two other ways that we have sensation, though. And the most important of those is interoception. What this really means is our ability to sense what's going on inside of our bodies. Usually that's completely below our level of consciousness, but occasionally when we have severe things going on, such as menstrual cramps or bowel obstruction, or we get severely nauseated, those sensory sensations will rise to the level of consciousness. They're also absolutely necessary for the feedback loops of the autonomic nervous system to regulate blood pressure, heart rate, pulse, maintain temperature, all the things that we do automatically without thinking about them. When those nerves, the nerves that drive interoception, are damaged or not functioning properly, then patients can have really severe problems. And so in taking a history and listening to the types of problems the patient has, you have to be thinking in terms of this interoceptive autonomic nervous system. For the visceral organs, as we mentioned, a lot of this comes up through the vagus nerve, 10th cranial nerve. The last sensation, which I mentioned in part as part of our sensing of the world, but is really more sensing of ourselves in space, proprioception, where are we in space, the body wall and into the limbs. Finger, very gently brushing with cotton is very good at all. To do this, we ask the patient to shut her eyes and tell us where we touch her, both which side of the body and approximately where on her body we touch her. So we'll just start with simple touch. This is what it's going to